Okay, shock. We're going to talk about shock. There are 4 types of shock, 4 categories of shock, but they all have one thing in common, and that is that blood cannot get to organs or tissue. There we go. Can't get to organs or tissue in the body. And what does blood carry? Carries oxygen. So all forms of shock, oxygen cannot get to organs, can't get to the skin, can't get to your fingertips or toe tips. So that's one important thing that you need to remember. The other thing with shock, and you will never forget this once you see it, you walk into a patient's room and you can't really put your finger on it, but they look like they're in shock. The doctor says they're in shock. Other nurses say, oh yeah, they're in shock. They may not say what shock. They may not know at that time, but they know their patient's in shock. Once you've seen it once, every time you walk into a patient's room, you're going to notice it. It's just one of those things that once you see it, you never forget it. But let's talk about what things that you might see. And these signs and symptoms right here, they are pretty much standard for all forms of shock, except for one. And we're going to go over that when we get to it. It's going to be neurogenic shock. That has a couple of different nuances that once you realize those differences, you're going to be able to spot it. But most shocks, they're going to have, your patient is going to have a very weak and rapid pulse. And let's think through this. Remember in the last week, or if you weren't here last week, I like to walk you through the process of why things are happening. Because if you understand the why, then you're going to understand what's going on and how to fix it. So rapid weak pulse. Remember how I said the main characteristic of all the shocks is the lack of blood flow to the organs and fingers and toes. So if you don't have good blood flow, you're not going to have good pulses. So your pulses are going to be weak. You may even need to get a Doppler or a device that you can listen to the pulse with to hear the pulse. So weak pulse, it's going to be rapid, mainly because there's a lack of blood flow. Your blood pressure is going to be low. Your heart's going to want to compensate for that by bringing up the heart rate. So it's going to be fast and it's going to be weak. Cool, clammy skin. The body doesn't like to really perfuse the skin when it's in a state of shock. It wants to conserve that blood for what it feels is the most important organs, mainly your heart and your brain, mainly. So your skin, it's not going to get the blood flow it needs, so it's going to be cool to the touch. Again, this is not for neurogenic shock. Neurogenic shock, you'll actually have warm skin, and we'll get to that when we get to neurogenic shock. But most forms of shock, you're going to have cool skin because there's no blood flow. Confusion, loss of consciousness. These two can go together. And anxiety, restlessness. These three go together. When you don't have blood flow somewhere, that includes the brain, so that can cause you to have an altered mental state. Last week I was talking about restless patients. So if you have a patient who is pulling their IVs out and they can't sit still in the bed, that's a bad sign. There might be just that they want to get out of the hospital, but there might be an underlying reason. So you need to figure out what might be the reason. If the patient was fine and all of a sudden they start to get a little loopy, they're a little confused, then that could be a good sign that your patient is going into shock. Decrease in urine, that's a big one. Like I said, lack of blood flow to the kidneys. In this case, you're not able to filter blood out if blood isn't getting to the kidneys, so you're not going to be producing a lot of urine. And then Mottling, that can go with cool and clammy skin. Mottling, that's when you have your skin kind of looks purplish, pale, splotchy, and I'll show you a picture later. That's one of the things that when you walk in and you look at their legs, or you look at their body and they're mottled, it's not a good sign. It's something that you'll never forget when you see it. All right. So let's start with shock, or obstructive shock. Oops, sorry. So in all these categories, you're going to see the cause of the shock within the name. So an obstructive shock, that's basically what it is. Something is physically obstructing the blood flow to the rest of the body. It's physically obstructing it. We're going to talk about each one of these. First, let's talk about, wrong thing. First, let's talk about cardiac tamponade. It's a form of it can cause obstructive shock. And this is when fluid, if you see here, this is the sac that surrounds the heart, the pericardial sac, which is a weird word. Anyway, if you have a trauma, or if you have some sort of physical, some people, it can happen spontaneous. That's not really common. It's very, very rare. But you have blood starting to build up, blood or fluid build up in this pericardial sac. And it's very fibrous, so it doesn't really explode outward. What it does is it pushes inward. And as you can see in this picture, if the heart is being compressed, what happens is blood can't get in or out of the heart. So as the heart gets smaller and smaller, you're not getting blood pumped anywhere. So what does this patient look like? Well, you're going to have a backup of blood, right? You're going to look at their veins here in their neck, and it's going to be backed up. They're going to be bulgy. You're going to have, like I said, your cool, clammy skin. Your blood pressure is going to be low. One of the telltale signs is when you listen to their heart, it's going to be very, very quiet. It's very muffled. And that is because, that is because the the heart is getting compressed and it's got fluid around it, causing it to be very quiet. You can figure this out mainly through an ultrasound. This is an emergency. If you don't get that pressure relieved off of the heart, what's going to happen is you're just going to not have any blood flow, and that includes to the heart itself. So that needs to be drained. They usually do a pericardial centesis where they stick a needle in and they draw the fluid out, but it needs to be drained pretty quickly. I had when I was in nursing school, my instructor told us a story of when she was a nurse practitioner in a cardiac clinic, and she was actually the last one to leave the clinic. She was just finishing up some documentation, and a patient just happened to walk in, a patient who was being seen there, and saying, "Man, I have some really bad chest pain." She was like, "Well, I'm about to close up, but let me take a listen to you." So sat him down and listened to him, and she's like, "Man, I can barely hear his heart." Went ahead, did an EKG, saw there was some changes in the heart rhythm, and realized that her patient was in cardiac tamponade. Called 911, and he actually lived But if she had not caught that, if she had not recognized it, if he just said, it's just a little chest pain, he could have not made it. So, like I said, medical emergency. You got to get that fluid drained. All right, 2 other types of obstructive shock. I'm gonna make this smaller so we can see the other pictures. And get rid of this line. We're at. Okay. Let's talk about pneumothorax first. Sorry. Press the wrong button. I'm going to get the hang of this eventually. Okay. Pneumothorax. So what's pneumothorax? Pneumo is air. Thorax is your chest area. Air in the chest. What can cause a pneumothorax? Let's think about that real quick. It's when you pop the lung, basically. So that could be a blunt force trauma. It could be, a stabbing into your chest wall. Anything that can cause air to leak out of the lung and in the pleural space. So the pleural space, just like the heart had a pericardial sac around it, the lung has a lining as well here. And it's also very fibrous. So when a hole gets poked into the lung or spontaneously, you can get air leaking out into that space. Well, it's very restrictive in your chest. So instead of pushing outward, it starts pushing inward. So your lung starts to collapse. Well, what happens if that doesn't get treated? Well, this lung goes this way. That causes everything to shift over. And that causes this lung to start to get shifted. So everything gets shifted over. So with that compression, it causes an increase of pressure in your chest cavity here. The intrathoracic pressure. Pressure in your chest cavity increases. When that happens, you've got all this pressure pushing down, pushing into you. Your blood flow is going to be restricted. Blood is not going to push against pressure very well. So what happens is your blood can't get up. It gets obstructed. Joink. From here, gets obstructed. Joink. So you don't have blood flow going to your heart. You don't have blood flow going to the rest of your body. And that's what causes the obstruction for this obstructive shock with a pneumothorax. The same thing happens here. Let me erase. Same thing will happen with a hemothorax. What does hemo mean? Hemo means blood. What does thorax mean? Thorax means chest cavity. So if you look here, instead of air in the pleural space, you got blood. So blood is now the mechanism. You got blood pushing up on that lung, which can cause that lung to shift over this way, causing this, the whole mediastinal shift that way, causing an obstruction. Blood can't get in here. Blood can't get in here. And therefore, you got obstructive shock. How do you treat this? Well, like I said, with the heart, you gotta drain. You gotta drain the blood. With the air, you gotta put in a chest tube, hook it up to suction. We need to draw that air out. We need a way for that air to escape. Once you relieve that obstruction, you relieve the shock. So you gotta figure out an obstructive shock. You have to figure out what is obstructing the blood flow. You need to fix that obstruction, and then blood flow will be restored. Any questions on that? Okay. Let's move on to the next one. These pictures, by the way, I got from Google. I just Google searched them. Cardiogenic shock. Now, I don't really have any pictures for this. We're just going to kind of go over and talk about it. So, like I said in the beginning, the shocks are told, or the types of shocks are in the name of the shock. Cardiogenic. Cardio is heart. Genic is origin. Starts with the heart. So this type of shock, lack of blood flow to the body, is because the heart can't pump anymore. For some reason, the heart cannot pump the blood to the rest of the body. So, if it has to do with the heart, what are some things the heart does to pump blood? Well, it's a big muscle, right? So if we have damage to that muscle, we have damage to the pump. What causes heart muscle damage? Well, you have injuries, actual physical injuries like, a blunt force trauma like a punch or hitting the steering wheel. But one of the main ones is heart attacks or myocardial infarctions or MIs. That's going to cause muscle heart damage. Now we can fix that by taking the patient to surgery or taking them to cath lab, and we can actually fix cardiogenic shock quickly if we identify it quickly. Or the muscle will go on to die, and then we have to fix it, the cardiogenic shock, by making the most of what muscle is left of the heart. Talking makes me thirsty. All right, irregular heart rhythm. So what is an irregular heart rhythm? If you look, and we'll go over rhythms, maybe next week we'll talk about rhythms, basic rhythms and whatnot, but when you have an irregular heart rhythm, remember, your heart normally is regular, right? You got the QRS, you got it pumping, it's got beats. Well, when you have an irregular heart rhythm, it can pump and pause, it can pump again, it can pump. So you never know when blood is going to get spurted out of the heart. And if the heart doesn't have enough rest time in between certain beats, it's not going to fill up with blood enough, and therefore it won't be able to push out blood to the rest of the body. So an irregular heartbeat can cause cardiogenic shock or lack of blood flow to the rest of the body because it doesn't have enough filling time to fill up with blood, or it just doesn't push out enough blood to the rest of the body. Very slow heart rhythm. So this is not a marathon runner. This is not a elite athlete slow heart rhythm. This is a very slow heart rhythm, probably in a very sick heart. And when you have a slow heart rhythm, think about it. You're pushing blood, but then there's nothing happening for a very long time. And you're pushing blood, then nothing happening for a long time. So maybe you have the blood there and your heart is pushing blood, but it's not pushing blood fast enough for the rest of the body to get the oxygen it needs. So that's cardiogenic shock mainly. Heart rhythms are fun, so maybe we'll do that next week if we don't have any questions. I hope we have questions though. Ask questions. Distributive shock. This is my favorite. Distributive shock is my favorite category. I don't know why. I just like it. Except for neurogenic shock. Anything that deals with nerves and the neurological system, I'm not a huge fan of. I mean, I do it because I'm a nurse, but it doesn't interest me as much as the other ones. All right, so distributive shock. Again, type of shock is in the name. Distributive means the blood is not being able to be distributed to the rest of the body for some reason, in this case, the blood vessels, the arteries, something's going on with the arteries, that arteries themselves are not distributing the blood. Usually it's because the blood vessels just get big and floppy and leaky, and they just don't want to do their job. And we're going to go over the different reasons why they get floppy and lazy. Let's start with anaphylactic. That's kind of the easiest, right? We all kind of learn that early on in life. So anaphylactic, that is an allergy where you have a reaction to something, and it's an immune response to a stimulus. So in this picture here, you can't read it very well. And this picture here kind of talks over what the stimulus does in the body. But basically, you have a stimulus that happens. In this picture, it's a bee sting, but it could be allergy to peanuts. It could be an allergy to shellfish, whatnot. But that triggers an immune response, and it causes all your blood vessels to just dilate. Just bleh. When you see this patient, you're going to see really swollen face, swollen lips. You may see a rash. It happens very quickly. Usually these people have to carry their EpiPen on them to give themselves a shot of epinephrine that constricts all the blood vessels, and you need to get them to the hospital. Even though you gave them an EpiPen, you need to get them to the hospital. Okay. Lost my train of thought here. Give me a second. I've only seen one case of anaphylactic shock in my career. When I was working in the ER, we had a patient come in. She had dinner at Red Lobster, and she had a known shellfish allergy. I'm not sure why you would go to Red Lobster if you have a shellfish allergy, but in any case, she had some chicken or fries or something, and it was fried actually in the same oil that they fried the shrimp or shellfish in. They fried everything in the same oil, and caused her to go into anaphylactic shock. She came into our ER. We gave her epinephrine, and we ended up having to watch her because some of the times these patients, even though they received epinephrine or epi, they can go back into anaphylactic shock. So you have to watch them over time. I don't think I had anaphylactic shock, but it was something similar. They had to give me epi for it, but I stood in a fire ant hill and didn't realize that until someone told me. And I also had swelling. My tongue was itchy. I was itchy. It was miserable. But they ended up giving me epi. I didn't get to this state. I didn't get super bad with it, but it was very uncomfortable. But again, once you see anaphylactic shock, you're never going to forget it. Okay. We're gonna skip septic shock for a moment here, mainly because that's my favorite, and I like to save the best for last. We're gonna go to neurogenic shock. Neurogenic shock is when there's an injury to the spinal cord. And if you remember from the beginning of my beginning of this streaming session, this one doesn't really follow all the rules. Remember how I said we have a rapid, weak pulse? We have cool, clammy skin. Well, these patients, they have warm, dry skin due to all the blood vessels dilating on the skin. Instead of in other cases of shock where it constricts and some of the surface vessels constrict in neurogenic shock, they all dilate. You got warm skin. It's dry. It's not cool and clammy. Your pulse is also slow. It's not going to be rapid and fast. This is due to this right here. Sympathetic dysautonomia. I don't pronounce things very well. Basically, what's going on is that your nervous pathways here are being damaged. If you look here, it's damaged. So what happens is the pathways that cause your heart rate to go up because your blood pressure is low is not there. So your heart ends up being very slow, bradycardic. You have arterial hypotension, your blood pressure is low, and then your skin is warm. Okay, these patients also, they could have some lack of movement, so paraplegia or numbness, tingling, and it's all due to this, the nerve pathways being injured. Okay, any questions on those two so far? We're going to get to my favorite, septic shock. I don't know why septic shock is my favorite. It's been my favorite for a long time. I think because once I understood it, I understood what was going on. It made so much more sense to me, and I loved it. I loved figuring out how to treat it. I don't love the fact that my patients go into septic shock. Let me be clear, but I like being able to fix someone who is in septic shock. So what is septic shock? Well, that's when we have bacteria in our bloodstream, and the toxins from the bacteria causes a reaction to our blood vessels and causes our blood vessels to dilate. This is right here, modeling of the skin. So this, don't worry about scores and whatnot. I don't think I've ever, as a nurse, scored modeling. I just know that this is the start of something. When you see their knees getting modeled, their elbows getting modeled, it's like, something's not right here. When you see this is bad news right here. This person is really, really sick. You can see all this patchiness, this modeling. This is lack of blood flow. And usually their skin around that modeling is going to be very, very pale. So, septic shock, like I said, is caused by bacteria in the bloodstream. Anyone can go into septic shock. That's the crazy thing about septic shock. You can have a splinter or a paper cut, and you have risk of going into septic shock. That's why it's important to make sure you wash your hands or wash the area that got hurt so that you can prevent this. The other thing with septic shock is a lot of it can be taken care of with prevention. You can have patients in the hospital go into septic shock. Maybe they had a Foley catheter and they weren't receiving good Foley care, cleaning around the catheter. They develop a UTI and then end up going into septic shock. Same thing with a ventilator and pneumonia. And central lines. That's another big one. When you have a central line, like a PICC line or a line that goes directly to your heart, you got to be very careful and diligent when you have patients that have these lines that go into different holes in their body. I know that sounds kind of crude, but really, if we put things in our patients tubes in our patient, we have to be very diligent about making sure that those sites are clean, that they're taken care of, so that we don't cause a patient to go into septic shock. Let's see. So treatment for septic shock. Number one is antibiotics. There's guidelines that Center for Medical Services, CMS, puts out, and it's imperative that you get antibiotics into your patient as soon as possible. There used to be guidelines where you couldn't give antibiotics until you did blood cultures. You drew blood to culture out what bacteria it was. Because the thought was, well, the antibiotics is going to kill the bacteria that we're drawn for. However, we found that if we delay that time with antibiotics, the mortality or the death rate for the patient gets a whole lot worse. So time of the patient hitting the ER or the whatever place they go to in septic shock to antibiotics, kind of like with a stroke. Time in the door to antibiotics, time in the door to a CT scan or seeing the provider. For septic shock, you need to give those antibiotics. Basically, bottom line. Antibiotics is going to be the main treatment, is going to be the main thing that will save this patient. I've seen so many patients in septic shock. I think the very first one, again, there's going to be patients in your career that you will see and you will never forget, and it'll stick in your mind. And when you see other patients throughout your career, you're going to think about that patient, and you're going to recognize things quicker because of that patient. But this patient, I think she was maybe in her 70s. She was brought into the ER by her daughter. Her daughter drove her to the ER. She had just been discharged from the hospital, and she was unable to talk. She was very drowsy, just kind of looked at you, modeled like this picture. We took her blood pressure, and her blood pressure was 70s over 30s, super low. And come to find out, she was in septic shock from a UTI. So I'm not, since I worked in the ER, I'm not sure what happened to that patient. We ended up having to transfer her to another facility because the ER that I worked in was at a very small hospital. But I'll never forget that. The daughter kept saying, this is not like her. She's usually able to talk. She's completely with it, and she just keeps looking at me. So septic shock, like once you see it, you'll never forget it. There's been I could sit here and spend hours telling you about all the patients that I've seen with septic shock. But the main signs are going to be low blood pressure and then the modeling like this. Okay, I think that's enough about distributive shock. There's no questions. I'm going to move on. This is probably like anaphylactic shock. This is probably one of the easiest shocks to identify and also to fix. All right, so hypovolemic shock. What's in the name? Hypo, low, volemic, or volemic, volume. So low volume, low blood circulating in your body. So of course, if you don't have blood circulating in your body, you're not going to have blood going anywhere. So, couldn't find any good pictures, so you're going to have to be satisfied with cartoons. this is a person who is bleeding out, right? You can see all that cartoon blood. Looks like he got stabbed in the spleen. Maybe the intestines. I don't know. If you're stabbed in the intestines, you can go into septic shock. So he could go into septic shock after he gets hypovolemic shock fixed. Huh. Anyway, okay. So this is going to be something that you're going to be able to see right off the bat. It's very important when you see someone bleeding, especially like this, that you stop the bleed, because that's even more volume that they're losing, right? They're even changing some of the trauma stuff to quickly look over a patient to see if there's any signs of just massive bleeding, to stop that and then do your ABCs. But for the purposes of testing, stick with ABCs. All right, hypovolemic shock related to extreme blood loss or too little volume. So this person is losing a lot of blood. What is the treatment? Well, we have to fix the cause. We got to fix that stab wound he's got in his side. But you have to give him blood. When this type of patient goes directly into the ER, they can often give them whole blood, especially if they've lost a lot of blood like this guy has. Whole blood right off the bat. They have whole blood in the ER, especially at some of the level 1 facilities. If not, we, at my facility, we have a massive transfusion protocol. We get certain amounts of each product to help make up whole blood. On a patient who's losing a lot of blood, we'll actually do what's called level 1. It's a rapid infuser. It squeezes the blood in super fast, squeezes fluid in super fast. For this type of patient, they're going to have a low blood pressure, right? Because there's no blood circulating. What is one thing you do not want to do with this patient? You want to keep their blood pressure up, but fluids is not really the answer for this patient. Remember, with shock, we have a decrease in blood flow, and what is on blood is oxygen. Oxygen can't be carried on fluids like normal saline, lactated ringers. You actually need blood. So it's really important for this type of patient that you get blood into them. You don't want anything that's going to be not able to carry oxygen for this patient. Stop the bleed, everyone. First aid. First thing you do, stop the bleed. Prevent hypovolemic shock. All right, this picture, I'm sorry, I could not find any better pictures. What is another cause of hypovolemic shock? Dehydration. So you may have someone that just did not drink enough water and they were outside forever and a half. They felt like they could just stay outside forever. Or vomiting. If you have someone that is not able to keep anything down, even water, that could cause hypovolemic shock because they're not taking in any fluids. So the treatment for that would be fluids because they have the blood, they just don't have the ability to move that blood anywhere because there's no fluid to help move that blood. Think of it that way. So for that patient, you would give fluids. They probably need to figure out why they keep vomiting too. That'd be a good idea. And then you see this person here is stabbed in the shoulder. I think the other guy would have bled more than this guy. That's a lot more blood kind of spurted on his head too. But same concept. You want to stop the bleed, and you also want to give blood back. If you have someone come in with a knife in their shoulder, don't remove the knife. That might be even holding some blood from coming out, but that's another topic. All right, hypovolemic shock. All right, so going back to this slide here, we covered obstructive shock, covered cardiogenic shock, covered distributive shock, and covered hypovolemic shock. Remember, distributive shock has the 3 within it, anaphylaxis, septic shock, and neurogenic shock. Neurogenic shock, remember, does not follow all the rules because it has to do with injury to the nervous system. And it doesn't follow all the rules because of that. Is there any questions on this? There's a lot of stuff. A lot of stuff. I've only seen a couple patients in hypovolemic shock. Usually they patch them up before they come to me. Although there was one patient, it was actually a couple months ago. He was in hypovolemic shock. He had fallen and broken his pelvis. And the pelvis is a very vascular organ. So when you have a pelvic fracture, you want to be very careful moving that patient because there's a lot of vessels going in and out and everywhere in that area. But he broke his pelvis when he fell. He was an older gentleman and he had a low blood pressure. Well, he shouldn't have had a low blood pressure. He had gotten his blood vessels fixed, so we thought. Well, we drew some blood and sent it off, and his hemoglobin, which tells us how much, it's a good telltale quick lab that can tell us how much blood is in his body, was extremely low. So we immediately initiated that massive transfusion I was talking about. And I think overall, between all the blood products we gave, I think we gave like 23 maybe. But it was a very successful resuscitation, which is when we fix shock, it's called resuscitation. A very successful resuscitation, and as we were able to do the replacement of the blood in the different parts to where we fixed his hypovolemic state so that he could go to the interventional radiology to get the blood vessel fixed that was bleeding. So he ended up making it, but it was a very cool case to be a part of and witness everything being fixed in the process. So, well, that's all I really have for my stream today. Please, if you enjoyed learning today and you want to learn some more in the coming weeks, make sure you follow and subscribe. Ask questions. I'm going to say that all the time. Just ask questions. No question is dumb. I'll answer all the questions. You have life questions about nursing? Go ahead and ask them. I'll be here. As the school year comes back, I'll probably, depending on how many people join our conversation, I may go to twice a week, but until then, I'll see you Tuesday nights at 8 p.m. See you later.